Case scenario, 65-year-old diabetic hypertensive male, 102 kg, past history, angioplasty to ostial RCA, DES 6 months back, prasugrel aspirin, inferior wall MI, long lesion RCA, restenosis, PTCA done, 80 millimeters of stent, de novo type B lesion, both LAD and L6. So you have multiple lesions, ideal antiplatelet with apart from aspirin, DAPT for recurrent events, bridging therapy, DAPT score, high risk interventions are take home messages. So this is something, the clinical scenario that we are talking about. RCA lesion, OCT done, multiple stents, again new lesions, LCX and LAD. This needs to be intervened. Dr. Nikunj, over to you to introduce our speakers. Dr. Tarun Dave is our speaker, very senior interventional cardiologist from AIMS Delhi. He's passed out, first of one of the senior most interventional cardiologists from the town.
Thank you, Kamal, and organizers for giving. This is a, I would say, bread and butter topic for an cardiologist of antiplatelet agent. Case scenario already has been.
No, you are not audible, at least to us.
While you do intervention, there are some hiccups like this. Okay. Am I audible now? Discussed by Dr. Kamal, and the topic which I am supposed to cover here is a ticagrelol, an all-season antiplatelet agent with higher efficacy. You see, the issues here to analyze the case is a patient is a post-PTCA status, was already on prasugrel and aspirin, and now he presents within 6 months with a new onset acute coronary syndrome. And what has been said here, that it is inferior wall STEMI. Now, it requires, you see, the 3 stents, total length was 80 millimeter. So the original stent was put in the ostial RCA, and now you require 3 stents. That means there is not only restenosis, but also there was a de novo extension of the lesion in the RCA, plus the presentation itself shows that it is in STEMI, means there was a thrombus formation on top of it, in spite of being the fact that the patient was on prasugrel and aspirin. And there are other reasons also in the other vessels which are also to be considered, and now what should be the choice of this? You see, this is a very old slide from 2009 Plato trial, which gave us an information that compared to clopidogrel, which we were commonly using, the ticagrelol is a drug. Ticagrelol is a drug which is definitely superior compared to clopidogrel in primary efficacy outcomes, namely the cardiovascular deaths, occurrence of the myocardial infarction or stroke. So the composite endpoint of these 3 major cardiovascular events were significantly less, so it was showing that it is highly efficacious as compared to clopidogrel. Secondly, by increasing the efficacy, you are not increasing the bleeding complication. It also showed that at the end of 1 year, there was no change in the bleeding incidence between the clopidogrel and ticagrelol, meaning thereby that compared to clopidogrel, ticagrelol is definitely highly more efficacious without increasing the bleeding complication risk. So the number 2 talk that the clopidogrel should be considered here, so automatically you see can be challenged that it is less efficacious, and these patients already having 3 stents and 2 more required in LAD and circumflex. I think ticagrelol stands better. Let's talk about the Congrenorol, which is the third talk. You see, what is Congrenorol? It is an IV preparation. It is a direct and fast-acting antiplatelet agent. It increases immediately the P2Y12 inhibitions, and at the time of balloon inflation in the primary PCI, you get a effective, you see the antiplatelet effect. But if you compare it with, say, there is a study which compared the effect of Congrenorol versus the ticagrelol. The drug is effective, but we are not just interested in whether what antiplatelet effect it achieves at the time of balloon inflation. We are interested in finding out what is the angiographic markers of coronary reperfusion, ST segment resolution, or the microcirculatory parameters which are assessed by IMR and CFR. They all are not changed whether you use at the start of this primary PCI the Congrenorol or ticagrelol drugs. So the final infarct size, even it also doesn't change if you use ticagrelol versus Congrenorol. So the advantage of, in this particular case of using an Congrenorol, because the 3 stents are already being put, the PCI has already been done, so it doesn't justify the use of now the Congrenorol therapy. Now what the literature says, the recommendation says, you see in patients, the 2023 guideline says in all patients with ACS, you should consider P2Y12 receptor inhibitors in addition to the aspirin. So whether it is a ticagrelol or whether it is a, you see a prasugrel, it should be considered. Prasugrel is recommended in those patients who have to go, his anatomy is known, and you have decided that you are going to do the angioplasty. Where in case of ticagrelol, it is irrespective of the type of the treatment, whether the patient will accept angioplasty, whether patient will require CABG, or patient will be finally maintained on the medical therapy, the ticagrelol can be started. The only sentence which was added was that the prasugrel should be considered in preference to ticagrelol for ACS patients who are proceeding for PCI, but you kindly see that the level of recommendation was class 2A, level of evidence B, and we will just dilate on this. This statement was added based upon the finding of the ICER React 5 trial, which showed that probably prasugrel is little better than ticagrelol in those patients who are going to receive the stent. But there are other suggestions also that the patients who are receiving either ticagrelol or prasugrel, but if the patient is, you see, the less than more than 75 years of age, or underweight, or previous history of TIA, then prasugrel should not be considered. So there are caveats in use of prasugrel, even if the prasugrel is to be considered. Now there are certain limitation of this trial by which this statement was added in 2023 trial. One was that it was a limited study, mainly in the Germany, only in one country. Secondly, the trial itself has a certain limitations in its conduct. That in the ticagrelol group, you see 1.3%, and in the prasugrel group, the 14% of the patients, a loading dose was not given. That was a problem with the trial. Nearly 30% of the patients in both the groups, they were not on the prescribed protocol-related treatment during the study follow-up. And 20% of the patients in each arm did not receive the assigned treatment at the time of discharge, although they were considered in the analysis. So these were some of the flaws in the conduction of the trial. In the treatment analysis also, you see 20% of the patients were discharged from the hospital on the without the allocated medications. So this was also one of the flaws. And when the safety analysis was concerned, nearly 12% of the patient in the, you see from the ticagrelol group, and 1.1% from the ticagrelol group were not included. So you see, when you consider the safety analysis, you should have the proper number which has covered right from the beginning should be considered in the safety analysis, meaning thereby that the safety analysis which they have projected is also questioned. So there were a lot of questions on the conclusion and the summary which this trial gave us, and it requires much more trials with this consideration to really say that ticagrelor, the prasugrel is better than probably ticagrelor in this sort of setting. Otherwise, if you look at the literature, you see the both have shown an effective antiplatelet effect, and at the end of even 1 year, the benefits, what are the benefits of, you see the ticagrelor as compared to prasugrel is, that if you see in the comparison between the prasugrel and ticagrelor, you see the cardiovascular mortality is definitely better with ticagrelor as compared to prasugrel. What is more better with the prasugrel is the less incidence of the myocardial infarction. So here, if you want to consider a ticagrelor, you are likely to have less number of the cardiovascular death. The prasugrel, as we have already said, there are a lot of contraindications and which should be considered before prescribing this. Now, ticagrelor has a broad applicability in whether it is a medical therapy, whether it is a, you see the invasive therapy in the form of PCI or CABG, you can consider the ticagrelor. And if the patient requires CABG within 24 hours, you can take it even for the urgent CABG. Yeah. In this particular case, there is a question why the patient develops this ACS even though it was prasugrel. So there is an entity which is known as a prasugrel resistance. Like we have a clopidogrel resistance. I will not go into the details of what are the causes of prasugrel resistance, but here in this case, this may be applicable. And when you are considering a therapy, in this case, we have already received now 4 stents and 2 more stents are to be planned. Prasugrel was already there, and in spite of receiving the prasugrel when he has developed ACS, I don't think the prasugrel stands a good chance in this particular case. We have already said that the clopidogrel and ticagrelor are probably out of place for this particular case, and therefore the winner is obviously the ticagrelor. And I will end with a famous statement that the knowledge gravitates as the opportunity dwindles, but we have to take the path of wisdom because wisdom doesn't deviate as the opportunity. Thank you.
Thank you, Dr. Tarun Bhai. And now, to brighten up the red corner, we have an apt man from the land of oranges, Dr. Vinod Vijayan from Nasik. He's famous for oranges, right? He's going to talk about clopidogrel is the preferred antiplatelet given for his risk profile for a long term. Over to Dr. Vijayan, please.
Well, thank you very much, Kamal. This is my 3rd time I'm coming here, and always look forward, whatever may be our preoccupations. And really a pleasure to be with you all. I was just listening with amusement. The whole discussion is between prasugrel and ticagrelor. And I'm supposed to talk on something which appears to be not a point of discussion, clopidogrel. And well, that is what is given to me, and I will fight it out. Well, we can skip this part, introduction, where I have no conflicts of interest for this type of lecture. It is mostly for clinical trials. Now let's come to this case scenario. This guy is 65, elderly citizen. He's diabetic, he's hypertensive, and he's one of those faces you see in WWF, 102 kgs. He's already had a long stent to the RCA with a DES implanted, and while on prasugrel. And we assume that he's been not missing out medicines, and he comes back again with an inferior wall STEMI. He has had a long lesion. This part has been discussed. We were talking about de novo type B lesions, but in today's era of all of us are being experts in complex angioplasties, type A, type B, and even type C really don't matter. And of course, we are always worried about the length, and this would require revascularization. And the topic given was, would it be ticagrelor or clopidogrel or cangrelor, and not prasugrel? So just going by the way it has to be discussed. Now let me go back when this point was to be discussed. What was the learning objectives here? We were to talk in relation to depth in recurring events. This is the patient, within 6 months the event has recurred. We are talking in terms of bridging therapy. Probably, let's see why he requires a bridging therapy, because he is not in any acute emergency. And DAP scores, what is the relevance here? These are to be used only if the patient is going for a prolonged therapy. And the fourth point is the high risk interventions, about which a lot has been talked. So whenever we talk about patients with recurring cardiovascular events, a prolonged DAP will give substantial benefits by reducing the risk. And the duration and choice has to be individualized depending on various factors. So these are the risk-benefit balance. Whenever you are going for an extended DAP, it can reduce the events, but always increases the risk of bleeding. And those with a high risk of recurrence will be getting a benefit of extended DAP, and often it is beyond 1 year. It even continues, because coronary artery disease is not a one-time, it's a lifetime. And a personalized approach is important. And the emerging evidence, such as like the redefined trials, they continue to refine our understanding of optimal DAP duration and balancing the ischemic protection vis-a-vis the bleeding risk. And these findings indicate that in select high-risk population, extended DAP may be beneficial, but many of them have high risk of bleeding. A shorter DAP would be. Now, DAP score, which has been alluded, we have to discuss. You know, the score more than 2 would mean a favorable risk benefit for extended DAP beyond 1 year. In fact, you have to continue almost indefinitely, though there are no studies. And the DAP score will have several factors. You're seeing the points to which these are like age. He's 65. Diabetes the patient has. A prior myocardial infarction is there. We do not know about cigarette smoking. Probably he must be hiding it out, I suppose. And the stent type, we already have got more than 80 millimeter length of stent, and he's got 2 more de novo lesions. So this is what is important here, and we have to keep in mind. Now, why is it a high risk? What is the meaning of high risk intervention? These are complex percutaneous intervention, and dual is DAP is crucial to minimize the risk of stent thrombosis, which probably, here of course the clinical history mentions patient did not have stent thrombosis, but restenosis. Within 6 months it has occurred. And the considerations here would be, the challenges to us would be extended duration of DAP, the choice of P2Y12, the risk stratification tools like Syntax score. I would have used the Syntax score 2 in this case, but all the data was not available, and already which I've alluded, balancing the bleeding and ischemic risk, and the guidelines and the emerging evidence. Now, and monitoring and follow-up, we might even do genetic testing for polymorphisms to see whether there's a resistance. Now, the speaker had mentioned about Pegasus TIMI54 in NIJM, which had occurred. See, these are all trials. When we were talking about the earlier trials, these are 2007, 2009, and they stopped at between 1 to 3 years. And while what focused DAP with ticagrelor, it highlighted that long-term beyond 12 months must balance the risk. And given the patient's comorbidity, clopidogrel here offers a lower bleeding risk while providing sufficient ischemic protection. So this would be my counter to this Pegasus TIMI54. And long-term clopidogrel therapy is still favored in patients at high ischemic risk, but with lower threshold for bleeding complication, as supported by this and other long-term DAP studies. So please take this into mind. Now, bridging therapy, I would not want to give more, because we are not comparing. This is something like an acute. You know, when you have to take the patient for emergency surgery, and that also in a subacute. In emergency, you have no choice but to go immediately, which may occur something like if you have developed a perforation or cardiac tamponade and you have to undergo a surgery or a stent is lost. So these are the aspects of DAP. In bridging therapy, I would really skip this part, And now coming to basically there has been, if you see all the three drugs, the one which has been studied most in literature is clopidogrel. Right from the cure study in which there are early and long-term benefits, it has shown benefit. And in the PCI cure, as of course you will say this is not against ticagrelor, but it had shown benefit, and that is how it was the first antiplatelet which had come after along with aspirin. And even it has, since the patient has had, our patient, a STEMI, it is clopidogrel is backed by evidence to reduce the recurrent. This is the COMET CCS2 study. And look at the number of patients, 45,000 patients, vis-a-vis the other studies where we are 60 or 100 or so. So the result was that clopidogrel added to aspirin reduced the risk of death recurrent MI by 9 to 10%, and the benefits of clopidogrel were particularly noticeable in high-risk STEMI. And we were talking about this high-risk STEMI as one point. And the patient's need for long-term therapy necessitates a safe option, and clopidogrel's GI safety advantage is known very well. And this was the Capri trial we have talked. Now considering diabetes, now 40% of our patients, including this patient, is diabetic. Many of them say it is 60% of the practice. They are at a high risk of bleeding with antiplatelet therapy. And clopidogrel has been shown to have a more favorable bleeding profile compared to newer antiplatelets like ticagrelor or prasugrel, particularly in diabetic population, making it a safer choice, especially when you have to go for a long time. And this is what, I think this is a repeat slide. So now coming to the ESC guidelines which recommend clopidogrel as an option. I'm not saying that you shun others just because it's a debate. Here you see this beautiful slide, whether even in stable coronary artery disease and acute coronary syndromes. When even here, in whether we don't talk about bare metal stent or drug cutting balloon, even in between is the bioabsorbable, the resorb. And here, if there is a high bleeding, then it is between, it is always aspirin, clopidogrel, and in otherwise also, when we are talking about 1 month DAPT and high bleeding, you want to discontinue, again it will be, first would be aspirin, clopidogrel. If you want to continue, it is aspirin, clopidogrel. When it comes, when it comes to all three of them are given equal importance. And when it comes to a high bleeding risk, then again all three are there, and below also. And if it is it's not there, and if it is there, it is between clopidogrel and ticagrelor when it is to be given for a short period of time. This was the slide. Now, this is my own, I wanted to see how this patient would suffer. Specific scenarios where clopidogrel might be preferred or considered superior. Bleeding risk. Ticagrelor is associated with higher risk of bleeding compared to clopidogrel in patients with a high risk of bleeding and those with history of GI bleeding, which is quite high, advanced age, and low body weight. Here, clopidogrel may be a safer option. Of course, our patient doesn't fit into the low body weight. A patient tolerance. You see, clopidogrel, many of you would know, it's not mentioned. Others have forgotten that it has side effects like dyspnea, shortness of breath, and occasionally bradyarrhythmias. And if the patient experiences these side effects, switching to clopidogrel might be necessary. And ticagrelor, avoid it if there is bradycardia. Cost and accessibility is important. You have to give 2 tablets Modern Intelligence report, from the Coherent Market, the Market Watch report, and they are talking about clopidogrel's dominance and comparatively the global data dominance of clopidogrel, and these are the ones, and the market share again. So clopidogrel remains the most widely used P2Y12 inhibitor globally, largely because of affordability and established efficacy. Ticagrelor, despite the higher efficacy in ACS, it has a smaller market share due to higher cost, and it is gaining, of course, but still it has a very small market share. Prasugrel, often used in younger ACS due to potential potent antiplatelet, has a more niche market share, and Cangrelor has a very small segment. So this is important for Gujarat कि जब धंधे की मैं बात करो तो जो जीता है वो सिकंदर. So to summarize my talk, clopidogrel is the preferred antiplatelet, and it is to conclude. So this scientific feast by Kamal today, this was the course 7. So it is a 7-course meal, and we are lucky to be talking on that 7 by the master chef of cardiology, Kamal Sharma. That we are talking about evidence-based medicine. I hope you are enjoying the feast. And with clopidogrel winning heads on and tails off, I rest my case to the jury. And finally, what is the take-home message? I always say there is nothing like take-home message. At home, you should only take massage. Just whatever message you learn, keep it to you in the cath lab and in the hospital and walk home. Thank you very much.
Thank you, Dr. Vinod Vijan from Nasik, on this role of clopidogrel, the preferred antiplatelet agent, given for its iris. I see. Please. Thank you very much, sir. And Dr. Vinod Vijan, sir, has highlighted almost all the learning objectives of the DAPT and recurrent events, bridging therapy, DAPT scores, high-risk interventions, and before that, in blue corner, Dr. Tarun Bhai Dave also highlighted about the role of the ticagrelor as an all-season antiplatelet higher efficacy. Now let's go to this yellow corner, Dr. Vipul Kapoor. Cangrelor, that is the safest choice amongst the 3 options in the view of the LAD/LCX revascularizations later on this drug therapy in cardiology sessions, and role of antiplatelets in high-risk intervention, choice of the P2Y12 antagonist. Dr. Vipul Kapoor.
So I think everybody is equally confused. So I need to clear some doubts. Yes, so I need to start off with the third topic of this debate, and that is regarding Cangrelor. Earlier speakers did their level best and were in a lot of hurry announcing the winners already, but it never ends till it ends, isn't it? So let me talk about I'll be a bit more pragmatic because nothing has been discussed about Cangrelor per se. We know, yes, obviously, it's an IV drug. It is having a small share commercially, you can consider. But when we are talking about an acute event, then what drug works best, right? We talked about long-term therapy. We talked about safety, long-term, 1 month, 1 year. But what about the acute event that this patient actually had? Coming to this scenario, this patient has an acute MI, is a high-risk, problem, is an elderly patient, diabetic, hypertensive, previous intervention, obese gentleman, right? We do not know. There are a lot of assumptions here. We do not know what the clinical status is. We do not know whether this patient actually skipped his meds or not, because being on prasugrel, which is the most powerful antiplatelet, he still has an MI. It's a serious problem, isn't it? So therefore, there are certain assumptions here. We believe whatever data we have now, we need to work on that, and then let us chart out a new trajectory for this particular patient. So if you look at the learning objectives from here, like we need to look at the bridging therapy, which was not considered at all in the previous talks. The depth scores was there, which was definitely covered. Long-term high-risk intervention, safety, and efficacy. So now this we have already discussed, the clinical scenario. Patient already has now 4 days in place. He is an inferior wall MI. We do not know the clinical status, but we assume that it is possible that it is, the patient may be stable. It is possible that the patient may be really sick. That we do not know. But yes, what we have is this data and we need to work on it. Okay, so now what happens is, see, this is an emergent PCI, acute MI, you need to intervene, already a PCI done, right? Now, what are the challenges with oral antiplatelet agents that this patient was already on, right? You consider that if you look at these details here, right, there is a problem, the patient may be in cardiogenic shock, we do not know, patient may be ventilated, patient may have nausea, may be vomiting, he may have delayed bioavailability, right? The patient, you give medicines, he may just puke them out, you do not know what drug has gone, whether it has really been, efficacious or not, right? Whether there is a heavy sedation given for the, for the pain relief, whether there may be drug-drug interaction, there may be a delayed bioavailability. In fact, if you see 64% of STEMI patients with, say, cardiac arrest, if you consider, they are unconscious. We do not know the clinical status here, but it is possible that this patient may be falling into one of these categories. So what do you do? Would you still give antiplatelet when you're not sure, when you want to take this patient for a PCI? So that is the, logical, practical problem. So therefore, there are definite limitations of oral P2Y12 inhibitors. Like all of these which we just discussed, there is a delayed offset, that is a delayed onset of action, cannot provide reliable antiplatelet effects, there can be drug-drug interactions. So all of these, underscore the need for an antiplatelet which can be useful, especially in people who are, say, even if stable, but they are nauseating, vomiting, they are in cardiogenic shock. That is where you require a potent antiplatelet which is safe, which is efficacious, and also fast-acting. Right? And that is where possibly, right, an IV agent may come in. But at the same time, you might say that what if I use a GP2B3 inhibitors? We have been using it for, long time in the past, but presently, unless there is a high thrombotic load, presently, the studies have shown that it may not be very helpful. Further, it may add to the bleeding risk. Now, in this scenario, it was a restenosis that was mentioned. There was no mention of a thrombus burden, but we assume that this patient had an acute MI, so would also have a restenotic, say, thrombotic infarct, and would have some degree of thrombus as well. So GPI, the problem is, particularly this patient was also receiving prasugrel. So you add on to it a bleeding risk, giving a GP2B3A inhibitor. So that is why, the problem, and we do not know whether reflow happened, slow flow happened. So therefore, indication for a GPI or glycoprotein 2B3 inhibitor is quite meager in this particular case. So, but we clearly know that antiplatelet therapy is a critical part of PCI. Any PCI that you do, antiplatelet therapy is absolutely indicated, right? And if you give it prior to angiography, and say suppose emergent CABG, suppose this patient went for a CABG, opted for, say, I would now go for a CABG, manage me conservatively, that's also possible. What would you do then? Because your antiplatelet, if you load them with ticagrelor or say again with prasugrel or whatever agent, say even clopidogrel, would take some time for offset. And that is where ticagrelor, say cangrelor, would be the ideal choice because it has a very quick offset of action. Onset and offset is particularly very quick. So therefore, though being a critical part, you have to balance everything. And for that particular patient, you have to make an ideal choice. So if you look at a clinical unmet need, an ACS, say non-STEMI, you have morphine, fentanyl, pain relief, you have high angiographical risk or complex anatomy, because if you remember, this was an ostial RCA stent. So again, angiographical complexity is already there. There is a known or potential need, say after PCI, this patient may opt for surgery. What would you do then, right? There is an inability to administer, say reliability of oral absorption, high risk comorbidities like diabetes, or even you may have renal or hepatic impairment, or even unknown renal status like in this case. So therefore, bleeding risk is high. So what about cangrelor? So if you see, it is a novel agent, right? It has potential advantages compared to the available antiplatelet agents. You just give an IV bolus followed by an infusion, very fast onset, very fast offset, and you can easily follow it up with, again, your whatever oral antiplatelet that you choose after the procedure if you plan a second PCI. So during this emergent PCI, I believe that we can load this patient very fast, take him into the cath lab, do the procedure, come out, stop the drug, and you can start your oral antiplatelets, whatever you wish, may be good for the patient. If you look at the mechanism of action, as we see, it is a P2Y12 inhibitor, acts on this coagulation cascade, and thereby, prevents the, formation of and dissolves the thrombus very fast. So pharmacokinetics, it has a very fast onset of action, 2 minutes, very superb platelet inhibition, almost 95 to 100%, which is far superior than any other antiplatelet. Very fast offset of action, within 30 to 60 minutes, the action is gone because it is a reversible platelet inhibitor and no dosage adjustment required with hepatic or renal impairment. So that again, your bleeding risk patients, right, with these impairments, that becomes a concern. So here, even if they have an impairment, dose adjustment is not required. So if you compare all these drugs, clopidogrel, prasugrel, ticagrelor, or even cangrelor, you can see here the offset of action, right? Half-life is about in minutes, not in hours or not in days, okay? And offset of action is very fast. There is no typical binding site. There is no prodrug involved here. So therefore, the onset of action is just in 2 minutes, right? And the indication is PCI in patients with or without ACS. So this patient had ACS, required PCI. So therefore, as a bridging therapy or as the initiation of the therapy, this drug may be the ideal choice. Okay, if you give the bolus here, you can clearly see within 2 minutes, the platelet action is coming down to almost zero, right? And moment the drug wears off, this platelet activity comes back. So you can see very fast onset, very superb efficacy, and very fast offset of action. Okay, pharmacokinetics, you can see the dose, 30 mics per kg bolus, 4 mics per kg per minute is the infusion. Immediately, just before you start your PCI, the bolus has to be given, and you start your PCI, and it has to continue for at least couple of hours. And once the PCI is done, right, the infusion is over, you can actually switch over to your antiplatelets. Guidelines, if you see, what about the recommendation by guidelines? So peri-procedural MI, US Food FDA, European Medicines, ESC guidelines. So P2Y12 receptor inhibitor naive patients, like in this patient, he was on prasugrel, so he was a receptor naive patient who is undergoing PCI, wherein a second drug of choice is required. Then cangrelor may be a very good drug. Oral therapy is not feasible or desirable. GPI may be high risk. In those cases, this particular drug may be very efficacious. If you look at the dosage and administration, we have clearly seen for at least 2 hours for the duration of PCI. Whichever is longer, for that particular duration, you have to give this drug. So this is how it is reconstituted, diluted, and you can give it in 250 ml, either saline or 5% dextrose, depending upon this patient being a diabetic, we can very easily use saline. He is an 100 to 2 kg patient, obese patient, so therefore the dilution would be, you might require 2 IV bags rather than 1. And you have a chart very easily available in your cath lab. So 102 kg patient, 15 ml bolus. So nothing of the calculation, everything is available. 120 ml per hour is the dose of infusion. You can give for 2 hours or the duration of the angioplasty, whichever is longer. And you can consider ticagrelor at any time during the infusion. You can very easily give ticagrelor or even immediately after the procedure. If you consider giving prasugrel again, you can give prasugrel after your cangrelor discontinuation. Or if you consider clopidogrel to be given, then even immediately after cangrelor discontinuation, you can easily give either of the antiplatelet for what particular choice that you consider this patient fit enough to give. Okay, so this is the administration, 50 ml vial, 50 milligram vial, and you can reconstitute and give it in an infusion. What about the trials? The Phoenix group, the champion group of trials. The most important one was the champion Phoenix trial, which was the landmark trial, which actually established the efficacy of this drug, because the 2 other trials showed that there was the primary endpoint was met, but there was not major significance when you consider mortality difference. But when they looked at the champion Phoenix trial, they noticed that there was a 21% reduction in thrombotic events compared with clopidogrel. So these are the champion study trials. They consider P2Y12 naive patients placebo or clopidogrel, and placebo or clopidogrel, and placebo or clopidogrel, and they randomize patients vis-a-vis clopidogrel, compared the trials with that, and they found that the endpoints were these, right? Modified intent to treat, stent thrombosis, death, MI, efficacy, and gastro-severe bleeding at 48 hours. So all these parameters were studied, and what they found was that all of these events were comparatively much less with clopidogrel, with cangrelor, and in fact the bleeding risk was also comparable or even to a certain degree considered to be lower. So if you look at this, you can see that ADP receptor inhibition with cangrelor significantly reduced the rate of ischemic events across the entire spectrum of patients undergoing PCI. So 22% relative risk reduction. So stent thrombosis within 48 hours, again that was 38% lower compared to clopidogrel. And if you look at all these endpoints, primary endpoints, if you see definite stent thrombosis, probable stent thrombosis, everything was comparatively lower with cangrelor. So these were the conclusions. Cantic trial compared crushed ticagrelor, right, compared with prasugrel. Same. What about GPI? As I was telling, you can see hospital stay, MI, bleeding, everything was lower with cangrelor compared to GPI. So again, that also is better with this particular drug. So I think I have covered my points well. It is up to the jury, the chairpersons, the audience here for this acute event, right? Possibly cangrelor may work the best, and possibly
If the patient, if we do not know the either patient is loaded with either prasugrel or ticagrelor, and if you again load with IV cangrelor also, is there any increased risk of bleeding, sir? Because this, like most of the time, sir, in day-to-day practice we face with this, because we do not know how the patient is loaded, either prasugrel or ticagrelor also.
yeah, I think most of the times, at least in Ahmedabad, we would know what the patient has already taken. If you ask him clopidogrel 4 tablets, ticagrelor 2 tablets, 6 tablets of prasugrel, something the patient or the relatives would definitely know, even if it is in a chit or whatever it is written. So I believe, that is where the cangrelor, in that case works very well, because, you are unsure of the status, and you would in any case load with something, isn't it? Whatever you give, suppose you are unsure, then possibly with this particular data that we shared, I believe with the efficacy and with the safety profile, I believe cangrelor would fit the bill the best, right?
Actually, most of the trials for this cangrelor is everything is compared only with the clopidogrel.
Obviously, most of the trials were, so the data would be with the baseline drug that sir also mentioned. Clopidogrel has the highest database, and we used it till recently. So clopidogrel was the standard drug till date. Possibly, and ticagrelor is part of the same family, so they won't compare it with ticagrelor.
Yes,
So the only drug that they would now compare it with would possibly be prasugrel. But when we consider a patient who is unable or who is vomiting or puking, then you have no other option, isn't it? Acute status, patient not stable, then in that case, the loading dose ideal choice would be cangrelor, right, rather than anything else.
I have a few questions on DAPT, sir. Vinod, sir. So first is when it comes to DAPT therapy, like after post PCI. So what is your stand when we compare the stable coronary disease and ACS patient, whether 3 months, 6 months, or 12 months? Or what is your stand on ticagrelor monotherapy after 1 month or 3 months of PCI?
Well, your question was de-escalation. You were talking.
Yeah,
Yeah.
Yes, yes, sir.
But I'll tell you, even one of this very important trials where, I was one of the PI. I've been in many of these studies. So we talk of de-escalation, but in real life, you will not see many cases unless there is a frank bleeding where you would want to come down. But I would continue because coronary artery disease and the risk is lifetime. We were discussing among us that all the studies we say you carry up to 6 months, 1 year, these are studies. But in real life, even after 1 year, I've seen patients, we are looking at, the disease progressing. We Indians as a subset are very different from what all studies are coming from outside. And I would, if nothing really, there is no contraindication, I would continue. And if at all I have to stop, I would stop aspirin, but continue any one of these. It may be in the form of, if the patient compliance is not an issue, it may be ticagrelor, or it could even be clopidogrel. But for reasons of compliance, I have found that clopidogrel is the most widely accepted. But your question is right. These are all as per the standard protocol, that if the patient is having a very high risk of bleeding, then you give these two drugs, and then within 3rd month, you de-escalate, stop one of them, And just like even ticagrelor also, after 1 year, we come to 60 BID. You know, it is available. But you can even make it earlier. But you have to be very careful. In that case, for the risk of thrombosis is always high.
So just after 3 months of DAPT, like the last trial, ultimate DAPT trial, which shows that after 3 months of DAPT, they switch to ticagrelor monotherapy. So would you consider the same, or you will if it depends on the patient's profile? Though you want to
I'll tell
continue.
you, it's a very relevant question you've asked. We are only talking of antiplatelets. We have forgotten many other things. See, today, even if a person comes, you give a very high loading dose of statin, reduces the mortality of procedure. We are now talking of bringing down, you know, for example, this patient, if it, let us stop thinking of the antiplatelets. He comes into our LAI extreme risk factor, extreme risk group, type C, where my target LDL, if I want to reduce his events, would be to keep the LDL between 15 to 20. These are new concepts which are, you know, being accepted. I would always look at his HSCRP. I would, you know, add this Goutnell and 0.5, which is again US FDA approved. All these factors together would then come and then really play a part, rather than only talking about an antiplatelet. And one question about, you know, what you mentioned, supposing if the patient is in a very acute phase, there is a thrombus which you're worried. Even if the person is vomiting, the initial stent thrombosis is not because of platelet. It is a coagulation. And most of the time, we give heparin around 8 to 10,000, and that is taken care of. And by the time the antiplatelets act, that effect is covered. I have used cangrelor in few cases where a patient had hematemesis, a stress ulcer, along with an infarction. And then there is no way I could, or anyone could give aspirin or other, and we had to use cangrelor.
Agreed. So I think the whole point of this debate was, I deliberately did not put prasugrel because the option that remains is that this patient can go for a CABG after addressing the culprit vessel. So you open up the culprit vessel. Why don't give CABG for the LAD LCX, bridge the therapy with cangrelor and send it across? Because prasugrel, you can't. Prasugrel, that's why the option was out. But again, with the new era of intervention, that's what I thought of. Ticagrelor and clopidogrel can always hold on. You can do an IVUS and stage PCI, fix the LAD and LCX. If your surgeon is not keen to operate within next 2 days, then any of the antiplatelets could have been okay. So the quiz was how, because the offset of action, you stop cangrelor, 1 hour, complete return of platelet function. And the quiz, I think Chirag got it last time, so did Karthik and Sanjay. Pratik gets the prize this time. So can we go to the next slide? Pratik gets the prize. Any other comments in the meanwhile? For the sake of time, we are playing the quiz in the discussion time. This is the answer. It says 60 minutes. Platelet function recovers within 1 hour. I'm not asking half-life. A lot of people voted for half-life. Half-life is 3 to 6 minutes. But the time it takes for the platelet function to come back so that you can take the patient for a bypass surgery is beyond 1 hour. So most of the times you stop cangrelor and take the patient into OT. After fixing the RCA, you have a hybrid lab, and the CABG can be done maybe on the same day. So, Dr. Vinod Vijan, can you get the prize to the winner of the quiz today? If there are any comments, any other comments?
One last question.
Yes.
Like just a case we discussed, the patient had undergone a PCI. Now within 6 months, patient presented with the re-MI, acute ACS. So if patient is drug compliant, would you like to change the molecule from ticagrelor to prasugrel, or you will still like to continue with the same molecule? Or you consider the platelet resistant in that particular patient?
So when the patient comes back with a re-MI and a PCI on an antiplatelet, you need to know whether it's antiplatelet resistance. Most of the times in the new era of imaging with aggressive post-dilatation, and patient is drug compliant, if it's not related to drug, then changing drug may not be mandatory. But if you think it's platelet inhibition, which is a problem which you can do by a platelet aggregometry, which a lot of institute got as a result of research in some of the clinical trials, you can do it on the bedside, see if the platelets are adequately inhibited already on the patient, which by the time, just like ACT you do, same way you can do a same time to platelet aggregometry in the lab. If it tells you, yes, the platelets are not adequately inhibited, more than 50% are still active, you definitely change the drug.
Thank you, sir.
Thank you very much. Thank you, chairperson, speakers, and our moderators. Thank you. We take a picture.